So welcome to Living Your Best During the Pandemic with Advanced Metastatic, Chronic, and Non-Curable Cancer, supporting the quality of life throughout the cancer journey. Today's topic is cannabis in cancer care with Dr. Mark Kerba. My name is Nikki, and I'm one of the staff at Wellspring, Calgary, and I'm so pleased that you could join us for tonight's speaker. We acknowledge that we live, work, and play on traditional territories in Alberta of the many First Nations Treaties 6, 7, and 8, Métis and Inuit, whose footsteps have marked these lands for centuries, and the gifts provided by elders and knowledge keepers. Living Your Best is a collaboration with Cancer Care Alberta, Wellspring Calgary, and Wellspring Edmonton. I want to take a moment and briefly introduce our speaker for tonight. Dr. Kerba is a GI, lung, and palliative radiation oncologist at Tom Baker Cancer Center and a clinical associate professor in the Department of Oncology at the University of Calgary Cummings School of Medicine. Dr. Kerba's research interests include health services research in the provision of cancer services, clinical trials at both the local and national level, including several research initiatives aimed at improving care for our patients with advanced cancer. Join me in welcoming Dr. Mark Kerba. And Mark, I'm going to pass it over to you now, and welcome everyone.
Thank you so much, Nikki, and to the Wellspring team, and to all of you out there in Zoom land. In Calgary, it's a beautiful sunny day. I really appreciate the attention that you're giving to this topic. I'm hopeful that with some of the discussions and the information that we are going to talk about and communicate today, that I can spur some curiosity, perhaps some improvements in quality of life, and perhaps like advocacy as well, and discussions with like your family and your healthcare provider around what medical cannabis means and what it means to cancer care. So I'll begin by sharing my screen. And so I've titled this topic, cannabis in cancer care, has it sprouted? Because it seems to me, for my practice and the years that I've been in practice, observing patients using cannabis for symptom control, that it's always just like on the cusp. We're always just on the cusp of perhaps a major study or a major finding that's gonna bring and give legitimacy to medical cannabis in cancer care. I'm going to hope to shed some light on that observation and maybe that viewpoint, that perspective, by reviewing cannabis, medical cannabis, its use, and potentially some areas of research that we could highlight and talk about after the presentation today. So this is a little quiz. Is this a sativa or an indica plant? It's kind of like a trick question. According to some specialists and experts in this area, in the pharmacokinetics and in the horticulture of cannabis, this is total nonsense to be able to separate out the plant and what it means, like a sativa, or I'm going to take an indica to help me with my symptoms based on the appearance of the plant. The reality is that the plant has been cultivated for hundreds, if not thousands of years, and especially more recently in the last number of decades. And in doing so, has lost maybe any intrinsic properties that it had attributable to the strain. And so one of the words that you hear when we talk about cannabis or marijuana is the word cultivar, which is the sativa or indica based on the appearance, but really what we're actually referring to is the chemovar, the chemical constituents of the plant that you're either growing at home, that you're using for symptoms or for recreation, or that the producer is providing to us as an extract or a purified product, or as leaves that we inhale or vape. So for disclosure, thank you, Nikki. I've been with the University of Calgary since 2007, and my area of research really is in health services with some clinical trials. but based on my experiences like palliative care and my patients like in GI and lung, I've developed like an interest in cannabis and looking how to better understand and integrate it into practice. I think it's time has come for that. So the objectives of this talk, like the first objective is to really review some of the history and the science behind cannabis, the use of cannabis, and secondly, the use of cannabis in patients with cancer, and then to touch on research and medical cannabis in cancer care, some of the gaps and some of the areas that are a bit more exciting or imminent, if you want to use that that term. And so, you know, when I put up that initial that initial picture, you know, the plant kind of looks like a sativa, but the word sativa typically means when in the context of somebody using like a sativa, is that they're looking for a bit of a euphoria, a bit of like a high, a disconnect, whereas like indica typically means that we're looking for potentially you know, a relaxation, maybe something to help you sleep, and this initially comes because of this terminology initially is derived from the initial maybe chemical constituents that the plant may have had prior to like all this like hybridization. So for all intents and purposes, the pure sativa, pure indica, with like those constituents and those cannabinoids, which we'll get to, is not like in existence. Little known, there is a plant also called ruderalis, which is a bit of like a hardy strain with like very low THC content. And essentially, when we're discussing the idea of like hemp or hemp like oil, we're talking about a plant that has very, very, very little, if no, THC available, so it doesn't cause like any of those psychotropic like effects that we attribute to marijuana or cannabis. So cannabis in the plant is what we call like a phytocannabinoid. So phyto, because it's derived from like a plant, and typically we associate the word like THC with getting, let's say, maybe getting a high or some of the central nervous system effects of like cannabis, but really it's inactivated. It needs to be activated, and to be activated, you need to apply heat. And there's like a fine line. There's a whole like chemistry like around this. Too much heat, a lot of it like evaporates and gets converted to like other chemical constituents. Too little heat, it's like very inefficient. So when you think about the use of like cannabis and like studies and different like effects, not only is inhalation, the mode of consumption or administration of the product important, but also how that product is activated is extremely like important, because it changes like the chemistry. So there's you need to remember there's a chemical product here that gets like activated, and that chemistry is like extremely like important. And a similar process happens with CBD, and I'll get to you know, covering like all these chemicals in a little bit like more detail. So the history. So you can say that the history is brief, but actually it's only brief in the way that I'm going to tell you, because it's been used for millennia. And so if you go back to ancient Chinese culture, 3,000 years or so BCE, it was used. It was like described in medicinal texts. Same thing with like ancient pharaonic like Egypt. It was used for glaucoma, for arthritis. It's in texts and medicinal texts from like the Roman and ancient Greek like eras, and essentially had been used for thousands of years. And up until kind of like the Middle Ages and a little bit like after that, was used in Europe. But with the advent, I guess, of the Enlightenment and maybe the Industrial like Revolution, and just prior to that, some of the awareness of medical cannabis use kind of like fell by the wayside or disappeared from Western like culture. So it wasn't until O'Shaughnessy, an Irish medical like doctor, from Limerick, of all places, Ireland. That'll be easy to remember. That's a question at the end. We traveled to India and was essentially a creative inventor, scientific individual who essentially rediscovered for himself the use of like medical or the use of like cannabis, and essentially brought this back to England in the 1840s. And very quickly, it was like adopted into the armamentarium of healthcare like practitioners of like the time and industry. You can see the vial there. Lilly and like other companies that were available like at the time would actually take the plant, develop like an extract, bottle it, and you could essentially purchase it, have it prescribed, and purchase it from a pharmacy. So what ended up like happening? So why, with this like important like history, do we have this like medical or this cannabis like dark ages of the last like 70 to like 100 years? Well, essentially what happened at the turn of the century, the 1900s, like in the United States, was that they had like an immigration problem on their southern border, and there was, to be frank, racism against Mexicans and individuals from like Latin America. And the term like marijuana is essentially is believed to be like a derogatory term referencing those like individuals and their use of like cannabis. So Maria and Juan. And what happened is during the Prohibition like period, when the U.S. government came down on, I guess, like delinquency with like alcohol and heroin and other like opioids, they at the very end, like in the early 1930s, came down unexpectedly, according to the American Medical Association, on medical cannabis as well. They essentially imposed regulations and costs like onto physicians for authorizing and for like dispensing medical cannabis, and with like all the restrictions and the lack of like production, essentially the common medical like knowledge and that had developed in the many years before that had like kind of disappeared from conventional medical education. And similarly in Canada, the same process like occurred. Marijuana became criminalized in Canada, maybe a little bit like ahead of the US. And it only was into the late 70s, maybe with the early 70s, late 70s with the counterculture, and then later with like HIV, AIDS, and the observation that cannabis was a useful medication to alleviate like symptoms attributable to the disease, that more medical attention began to be focused from a clinical setting on this, and this started to spill over that maybe with like advocacy that we could change the regulatory environment around this. So you need to think that in Canada, this is essentially a criminal. This is a product that is associated with criminal like sanction, and in the U.S. it was regulated up there with like heroin and LSD in terms of like prohibition on it, basically saying that there is nothing that is medically useful in this like product. And that was, I believe, added on a bit later. So between like the 60s and the 70s, it became like a Schedule I drug, and so everything was like lumped together. And so we had like all these controls, and so these controls began to lessen with like this advocacy and these observations, and some studies that began to take place describing the usefulness of like of cannabis in treating like anorexia from HIV, or chemo-induced like nausea and vomiting, and spasticity and MS. And so there was also work being done by industry to try to purify the active like constituents, the THC and CBD, so that this can sort of like avoid the regulatory environment and make it in with to prescribers with like a DIN, but recognizing that cannabis is much more than just like THC or CBD, and perhaps that there was like an over-regulation slowly from like 2001 through to 2014, 2016, and reachable like on that researchable like on that link. We could appreciate that over the years there's been some relaxation of the prohibitions on cannabis. There really was like Bill C-45 that received royal assent in June of 2018 and then went into effect like in October of 2018. That changed like the regulatory framework substantially, and that's what we're living with like today. There's still, I mean, it's still within the criminal like act, criminal code in Canada. It's illegal to possess more than 30 grams of dried cannabis leaves. You can't, I mean, not that anybody's knocking on your door, but you can't cultivate more than 4 plants. You can alter cannabis like at home into an edible, but you can't do it like somewhere else. You need to purchase from like a federally licensed producer. But essentially the framework that they adopted was the same framework that they adopted going after big tobacco. So some of us that are old enough, I think most of us here on Zoom, recall the, Du Maurier, fireworks, the sponsorship of Formula One and other like events that were held with like tobacco money. And so the fear or the concern was like at the federal level that this could be reproduced with like medical cannabis like producers. And so there's a strict lockdown like on any advertisement to prevent like any inducement to use like the product, to protect children and teenagers, and to protect essentially society from itself in some way. So the issue from like a clinician and a researcher like looking at this like regulatory framework is that it came down compared to like other countries a little bit like too strict and made it extremely difficult to conduct like any studies because producers are unable to do to get their product out and funding in a timely or in a way that meets like regulations from like Health Canada. So that's why like everything is maybe could go a little bit like quicker than it has been. And so there's been advocacy on that front to push for it. So we're hopeful that will might change within the next year or two. So regulations on the medical practitioner. We are, as like physicians, not necessarily like opposed to prescribing like medical cannabis, but what we desire, just like our patients, is like having the information to know what is reasonable to use and when is it reasonable to use it. And the college essentially recognizing some of the uncertainties like in that the College of Physicians and Surgeons of like Alberta essentially requires a physician that desires to complete a prescription or an authorization for like medical cannabis to register with like the college. And there are steps that need to be taken to ensure that follow-up is like adequate to minimize harm and to protect like patient and society. But the sky is not falling. If we take a look over the last like 5 years and use household expenditure on alcohol or tobacco and cannabis for medical use really isn't going anywhere that quickly. There's a lot of non-medicinal or non-medical unlicensed like use that is being spent on. But what I'm hoping to like also illustrate like here is perhaps the disproportionate regulation of like medical cannabis compared to tobacco and alcohol, which are known to cause exponentially more societal like harm. So where are we these days? So in Alberta, cannabis use compared to the other provinces is maybe a little bit like higher. This is the proportion of Canadians older than 15 that have used cannabis either for medical or for recreational use over the past 3 months. And this is in keeping with some of the survey results that I'll show. The lifetime use of cannabis is only slightly higher than it's been like over the last 5 years, but it's somewhere in the neighborhood of 40 to 45% ever used. And that is that's like an important consideration because it speaks to the willingness maybe of some patients to engage with their healthcare providers or consider using medical cannabis. And so just for curiosity, just looking at it by gender in terms of differences, one of the things that is a little bit striking is that women are a bit more likely to obtain product from friends and family as opposed to males and how they obtain their cannabis for either medical or recreational uses. There are perhaps 10% of the population that use it on an almost daily basis, but almost half the population is likely not receptive yet or doesn't find a need to use medical cannabis. So hopefully with information that I'm going to be continuing to share with you tonight, that you'll be able to take some of that and talk to your friends and family to better educate them around what what cannabis really is and what it could potentially be used for. So some science around this. So the active product in cannabis, CBD, and then THC was uncovered 60, 70 years ago. And that's not to say that there aren't hundreds of other constituents in cannabis, but what was believed to be the active constituent was first isolated in 1964 by Dr. Meshulam, who's now in Israel. And it wasn't until 1988 though that the receptor was discovered, and that essentially speaks to why we didn't learn about it in perhaps the way we could have learned about it when I was in undergrad in the early 90s, or in medical school after that, just because it was a new discovery. And so the next step was essentially discovering and cloning the THC receptor, finding that it was in the brain, then discovering the CB2 receptor. There's a second cannabinoid. Essentially, there's only 1 and 2, and these are segregated. There's overlapping in different tissues in the body, and they are the targets of THC and CBD, and they are how THC and CBD exert their effects. So something that's quite interesting. We've all learned about, you're running and you get a runner's high and you attribute it to endorphins, but it's actually not an endorphin. It's actually an endocannabinoid. It's a cannabinoid that your body makes in the post-synaptic neurons. So neurons connect with each other. There's one before and there's one after. The one afterwards basically makes this product, and it goes back to the receptor before, and it modulates it. And that modulation creates a euphoria. And that is also involved in the reward system and in motivation for activity. And there are two primary endocannabinoids. Anandamide, which, as you can see, is derived from the Sanskrit word for bliss, and just for short, 2-AG. So this was also discovered by Dr. Meshulam's group, and this binds to both CB1 and CB2 receptors. So you have chemicals that the body makes itself, which is just like THC that you get kind of from the plant. But the plant carries everything else with it. And this endocannabinoid system is essentially hundreds and hundreds of millions of years old. So amphibians, birds, dinosaurs, essentially any animal with like with a nerve network, except for insects, would have like an endocannabinoid system. So it modulates everything. And so like in the body, using like this diagram, you can appreciate that the CB1, even though it's like red because CB1 and CB2 is present, it's present like in the brain, in the lungs, like in the bowel, in the muscles, and then you have like CB2 receptor in like different parts of the body, in the spleen, the bones, like the skin, so the immune system. And so the immune system like overlaps, the liver like overlaps, the bone marrow overlaps. And this is where it's postulated that the effects of modulating like your endocannabinoid system, like that, this is where like the health benefits are postulated to come from. So it's developing into a more exact science, but it's not. There's a lot to learn about the human body. It's quite complex. So at the synaptic level, this is what I was like trying to illustrate, that you have this presynaptic neuron in kind of this like almost like teal, the shade of blue at the top there. It's releasing a neurotransmitter to like the other neuron to get it to send like a signal for activity or for sensory. And then once that neurotransmitter attaches to the other neuron, there's a mechanism by which the anandamide and the 2-AG are made, and then basically sent out. They migrate out of that cell, and then they bind to this like CB1, this kind of curvy line that you see here. That's just a receptor, and then that turns off the neurotransmitter to begin with. So it's like it's basically a feedback. It's a feedback loop. So your endogenous cannabinoids feedback, but you can use a plant-derived cannabinoid. It could be THC. It doesn't have to be THC to like modulate it and get those like hopefully medical benefits. So what's in it for you? There's like hundreds of compounds that are in it for you. Most of it is of the non-cannabinoid type. So that would be terpenes, oils, other chemicals and things that are typically in a plant. And then you have, specific to cannabis, the cannabinoids. Some of them are psychoactive, many of them are not. And it's in knowing and understanding these cannabinoids and how they interact with the body where we will be able to better learn how to derive like the benefits from the plant, right? So this kind of like illustrates, like in the circle, you can appreciate that CBD, like in blue, exerts many effects. A lot of this is like derived from like obviously from like basic like science, but it's hard to say that, you know, if you were looking to pick up like CBG, some strain that was advertised as being high in CBG, that it would have like an antibacterial property that you could use like instead of an antibiotic. I would definitely not recommend that. I think that this is like a starting point for the science, but the reference is there for those that are interested in learning a little bit like more. And this doesn't, like I said, doesn't speak to the multitude of other compounds that are intrinsic to the plant. So given all of that that's going on like in the body and with the plant, this led, like as I was describing like earlier, in terms of like the history use of like cannabis and smoking cannabis during the HIV/AIDS epidemic of like the early 80s, and it has been found and has been subsequently proven in studies that THC does have like an effect in terms of controlling and helping with like anorexia. We know that CBD is extremely like powerful in some anti-epileptic, as an anti-epileptic in some disorders. And recently there was an approval by like the FDA for a CBD product from plants, an extract that could be used in children. So that's a big breakthrough. In chronic non-cancer pain, there's evidence like supporting this, as well as in multiple sclerosis for spasticity, and for neuropathic pain as well. And so I would say that the established like indications outside of the anti-epileptic indication is easily found, like in this reference here from the National Academy of Science and Engineering in medicine. And if we jump to like the next like slide, we can appreciate that there's some formulation that is some formulations that are able to be purchased like in Canada, some in the United States that have received like approval, have like a DIN number that can be used. But once again, Marinol or synthetic like THC is basically just like THC. It does have like an anti-nausea product. It's very expensive. Some of these were developed like prior to some of the newer, stronger anti-nausea medications that we use with like chemotherapy or radiation treatment. So if you have coverage for one and probably don't have coverage for the other, it's not difficult to make a decision to see where that's going to go. And similarly with Nabilone as like an oral capsule as well, like there are a lot of challenges in terms of absorption, and it's also without some of the other chemicals that are available like in the plant. A lot of information here, but one of the other key words in the cannabis literature is the idea of like an entourage effect. So the idea that the effect of, let's say, THC or CBD is enhanced by some of the other products that are available or produced by the plant itself. So consuming an extract that has THC but has some of the other plant constituents is going to have like a different effect than if you just take like the THC and purify it and just take it from that same plant itself. That might work for CBD, for the anti-epilepsy, the bottom like indication that I highlighted. That's a plant like extract, but it's essentially pure, essentially a CBD that is used for children. A pretty significant like dose of like CBD. But for the oral like spray, it basically only comes like in one. It comes in one strength, like one ratio. And we know for cannabis, like for like other things, that you need to be able to like adjust the dose and to adjust and to consider the individual like variations that may affect its efficacy. So these are all some concerns around like some of the pharmaceutical cannabinoids outside of the plant extract at the bottom that has like a very strong indication and use that's changed like lives for children. Medical cannabis generally, when we're thinking about it, we're thinking about these buds, these plants that we can like smoke or vape, these tinctures, these extracts that we can use, that we can either ingest, put into like food products, or put sublingually for absorption. So this is like typically what is thought about when we're thinking about modes of administration. And we can also think about just like a general split, like in the same way that the receptors like in the body are in different like areas. Because of that, the effect of THC and cannabidiol is going to be different. And that's because it works like, because they work on different parts of the body in just in general terms. So a lot going on in terms of like the science. How can we translate that? How can we bring that to the patient with like cancer? So it's not uncommon for us to hear a story in the news or something that's like highlighted in basic science like research, that it looks like there's a signal, something is gonna decrease pain from cancer that spread to the bone, or maybe change like the course of the cancer itself. So this resonates like within like the healthcare providers and also with our patients. And so because of what I was explaining earlier with like my observation that patients were using cannabis, and because of the challenges in doing like any studies, one of my colleague, Dr. Martel, and many of my colleagues across like the province and I look to get a sense of like what is exactly going on with our cancer patients. No survey of this size or magnitude had ever been done in the cancer population like before. And so in 2017, prior to legalization, we undertook a survey to basically figure out the proportion of patients with cancer who were using cannabis and try to figure out the reasons for using it so we could better understand and translate some of that basic science research, all those figures that I'd shown before, into something clinically meaningful. So we thought that given what the population was using at that time, like maybe 5 or 10% of people would have used cannabis in the last month. So we asked some questions, we got ethics approval, and this was all like anonymous, and we're very thankful if to like all our cancer patients that completed this like survey. Asked them about something about themselves, their cancer background, their cannabis use, opinions on cannabis, their comfort with discussing cannabis with their healthcare provider. And we captured all adult patients across the 4 chemotherapy radiation centers across the province at that time. And we distributed like over 3,000 surveys over the course of essentially 2 weeks. And almost 2,000 surveys were completed. And so once again, we thank you all, because we were able to uncover that within like our cancer population, that 43% had used cannabis at any time. And so this somewhat validates our results in a way, or our survey, because this was like in keeping with what is observed in the general population. So that's a good thing when your survey is hopefully not missing out on any group of like people. But the majority at this time in 2017 had acquired, like 80% had acquired it through friends or acquaintances, and many of them, like so almost 86% did not have a prescription for it, and so they were basically using it on what they were able to gather without maybe any frank discussion with perhaps with like a prescriber. And so we noted as well that some patients were probably less likely to complete like the survey, the very elderly, so patients greater than 80 years old, and some people with blood cancers or skin cancers. However, across like all the cancer sites, we could see that at least 10 to 25% had used in the last 6 months, but that their lifetime use was in keeping with the general population. So something really was like driving patients across like all the tumor groups to use cannabis. So when we looked at this like in a little bit like more detail, we appreciated that that this like number really had gone up and was associated with the use of like therapy. So patients who were like on therapy, they were much more likely to use. So 230, so essentially 67% that were receiving therapy, because we captured everybody that was coming into the cancer center. So that was really a driver for usage in the last 6 months or even the last week. So among those 356 patients that were using like in the last like 6 months, 54% were on chemotherapy or immune therapy or some sort of targeted therapy. It's important, and we'll get to that later. 8% were on hormone therapy, so probably breast or prostate cancer. 16% were receiving radiation treatment, or 4 maybe had like recent surgery or something coming up. So when we cleaned the result and we looked at everything else, all the other variables that we had captured like in the survey, really being on chemotherapy, immunotherapy was extremely associated, extremely related to the use of like cannabis. And so this essentially is like meeting a need that we were surprised was not being perhaps like adequately addressed while on treatment by us, like their healthcare team. And so the other thing is that the cost is not trivial. Patients are spending between $100 to $500 to greater than $500, like in that 6-month period, essentially like out of pocket. And the other thing that is that's interesting is that they aren't just using it for, patients weren't just using it for their cancer, but were using it for other reasons as well. So there was predominantly a cancer-related reason, but non-cancer related reasons were also quite significant. So we see that on this slide, that for any non-cancer related reason, of the people using the last 6 months, like half of them are using it for something else in addition to their cancer. So we need to remember as healthcare like providers that patients aren't just patients with cancer, they're patients with arthritis, they're with patients with like anxiety or insomnia, and there's other things that we need to do that are perhaps exacerbated by their entry into the cancer system and their journey, that can be controlled or palliated better. And that is one of the drivers for medical cannabis. But medical cannabis, or cannabis, is meeting that need. One of the other things that we did in the survey was explore the thoughts around like cannabis use. And so patients, you know, a majority of them thought that, you know, cannabis did not cure cancer, but there was a proportion that did. There was a proportion that did not maybe agree, or they disagreed that cannabis interfered with other medications. There were a lot of people that were unsure, and a lot of my colleagues would be unsure as well. And so just to highlight some of those uncertainties and those responses. We also asked about and looked at the data in a way, and we found that patients that were younger and their education level, maybe their lifetime use, all affected their perspectives on the cannabis. So this, I think this is like an important factor that we can integrate better into our clinical like discussions with patients. So comfort level about this with discussions around like cannabis with oncologists are extremely like important. We were surprised that 548 of the respondents were unsure or uncomfortable or not able to like answer that question, and that many thought about using cannabis, but essentially they were not discussing that with their healthcare team. And I think there is a need in terms of like communication and our responsibility to patients to have like those discussion around things that are important to them and their health. So what can we do to better identify and facilitate like the proper use of like medical cannabis like in cancer care? So just this is kind of like the last survey that I'm going to show here. We my colleagues like and I supervised like an honors project student, Mr. Andrew McClellan, I apologize. And he was looking at the investigation of patients like knowledge and those of healthcare practitioners as well, around, you know, beliefs and values and preferences for cannabis and associations between their beliefs and anxiety, depression, and like other symptoms as well. So this project, our first project in 2017, led to this project. Essentially, this identified, not surprisingly, gaps in care. A majority of patients had not spoken to a healthcare provider. Majority reported not receiving sufficient information. Many would be receptive to the idea of like a cannabis program if it was there. And similarly with like healthcare providers. I mean, I recognize kind of stepping back from cancer care that there have been many groups such as like physician groups, pharmacy groups that have looked to put together like educational programs as part of like their accreditation, like around cannabis and medical cannabis. And I think that is possibly something that would help to remove some of the maybe the stigma and some of the clouds around the information and the lack thereof in this like space. So essentially back to the clinic. This is like complicated. This is complicated. Patients want to know how this might impact like on their treatments, on their symptoms. There are multiple symptoms. They're using it for multiple like reasons. There's other patients on a wide variety of like medications. What do we do? How do we test it? What do we look for? Well, the first thing that we need to do to try to like answer that question is kind of know a little bit about how cannabis like is absorbed and understand cannabis in the same way that we hopefully understand some of the medications that we're prescribing for patients. Inhalation, not all of it is like available bioavailable to have like a physiologic effect, but the effect is very quick. Oral ingestion, it can be variable because of just like how things are metabolized like through the liver and how that is different from like individual to individual, and that effect can be delayed. That effect can be delayed significantly, so that maybe, and there's you know, the reports of individuals consuming something and then not having an effect and taking another one, and then going in the car or and then suddenly being hit all at once, and feeling essentially like incapacitated to function well. Topicals are very promising, but studies around them are still like in development. There's some challenges because the cannabinoids are very they like fat, so they have to cross through like a water layer through like your skin. But one of the advantages, like advantages for medications given by patch, is that potentially you can get like a steady dose like into the individual. So some very smart people are working on those methods of delivery. So if we understand a little bit about how cannabis is absorbed, what about its safety? Well, it kind of depends on how it's like taken. I was kind of alluding to that with like the absorption. Generally, it's safe. I mean, you'll hear in the cannabis community that the likelihood of like an overdose, no one's ever died from taking cannabis or overdose like on cannabis. Well, maybe or maybe not, but certainly there are some side effects. Some of them might be mild, some of them might be more important to those with like cancers. There are precautions, and I'd say that there are contraindications. Like my colleagues Dr. Vincent Maida and Dr. Paul Danik did put a piece together, a user's guide to cannabinoid therapies in oncology, which I've highlighted there. So certainly any younger individuals, pregnancy, psychiatric like disorders, potentially compromised cardiac status. It's hard to know exactly what that means. History of like substance use, those doing essentially jobs where they need to pay very close like attention, and medications that might interfere with metabolism. We really need to be very careful, and that's because the side effects of like cannabis can cross like the gamut of like psychiatric, feeling like that high, developing like anxiety, developing like an impairment in function, racing like heart rate or low blood pressure. That can certainly be dangerous, and then other unpleasant symptoms such as dry mouth or a change in appetite or constipation, dry eyes or a cough. And CBD tends to have, this is THC primarily, but CBD can also have some effects, including like diarrhea or effects on liver function testing as well. So that'd be like important if you were taking cannabis or cannabinoid for, let's say, like your arthritis, and then your physician is monitoring your liver function test because they're concerned about a toxicity. I think those that line of communication needs to be open. So what else do we need to be mindful of? So it doesn't just end with like what I showed you before, but once again, it hits like the important organ systems, and also there is the suggestion that there might be an association with some head and neck cancers, lung cancers, and testicular cancers as well, with possibly prolonged use of cannabis. But this is confused because some of these studies aren't like a randomized like study; they're like a population observed like study. And like I was alluding to before, sativa and indica, who knows what you're consuming, and how that plant is being cultivated, herbicide, pesticides. You're inhaling it. What else are you taking at the same time? And so, just a word of caution there. So the metabolism is like an important thing for us, like in oncology. THC has its own metabolic like pathway. There's like a bit of an overlap with like CBD that can affect its like duration of like action, and essentially This is like well like described and known. Whenever a drug is like studied, this is one of the first things that's done, the pharmacokinetics. And so we know the pharmacokinetics of basically all the medications need to have like their pharmacokinetics studied prior to like any approval by the FDA or by like Health Canada. So what if you're on chemotherapy, capecitabine or 5-FU, or on abiraterone for your prostate cancer, on like an antacid or on an antibiotic? This might increase like your concentration of like THC. What if you're on ketoconazole, like an antifungal? That might really increase it. Usually we're concerned about the antifungals and how they potentially could affect metabolism. A lot of the small molecules, the inhibitors that are being used across like melanoma, renal cancer, lung cancer these days, they all like interact and affect like liver metabolism, which can also interact with like how THC and CBD is metabolized and how that can be used for symptom control. So cancer medications, like all the inhibitors, cabazitaxel, docetaxel, vinca, alkaloids, almost everything that you can name is like up here. To what degree is it important? Some of them are more important than others. Ketoconazole can have like almost like a 10-fold difference in like metabolism. So how something may affect the individual. And some of the small inhibitors can be like a 20 or 30-fold like increase as well. So much more than the ketoconazole, and some of them are like synergistic. So drug interactions are a big problem. Medical complications from polypharmacy is a big problem. Cannabis just adds like another layer to that. So going through all of that and going into the research that's there now and that we need to do, how do we integrate this all to better help like our patients, like all this science and these like observations and these considerations around like benefits and harms. So one of the things that kind of catches our eye, kind of like the poster child for cannabis in cancer, is I guess the story around like glioblastomas. We know that glioblastoma, multiform GBM tumors, they express like CB1 and CB2 like receptors. There've been like studies like in vitro, small patient like studies, like we're talking like under 10 like individuals, where some individuals together with like their chemotherapy and the addition of like cannabis have shown like a benefit. So small numbers. The science is pretty sorted on this, suggesting that there is a cell death like inducing benefit from cannabis. There's a cell division effect. There's antivascular like effects, so blood vessel growth like into the tumor is like affected, but it's like complicated. To what degree does this hold out in a larger study with like all the noise that can be there around like the extract? If you were to go into a search engine or into PubMed and put the reference that's there into PubMed, you'll pull out like articles that are similar, and you will see that we're just kind of like on the cusp. We're waiting for essentially like a large like study in this space to help like answer this question almost like once and for all. So this is, I would say, like exciting in this like space, but it's complicated, like most things in other cancers, because we know that cannabinoids modulate the immune system, and we're kind of transitioning to targeted like therapy. We have these targeted like therapies that can affect like metabolism in the liver that can interact with cannabis, but we also have immunotherapies that also can affect and can be of like can have huge important clinical like impact on cancer like outcomes, where cannabis is known to like affect some of the cells like in the immune system through the modulation of like the nerve and through direct like effects because of receptors being like present. And so this like interaction has been looked at a population like level. So some of the science has been done like over 10 years ago. So more recently out of Israel, because their healthcare system is structured centrally in such a way that the dispensation of like medical cannabis is also centralized. So you have many patients with like cancer that go for medical cannabis therapy that are followed in these like centralized like clinics. So they pulled their patients that had advanced cancer, like in the study, that were also like on immune therapy. So melanoma, non-small cell lung cancer, renal cancer, 51% of those patients were like on cannabis. So usually these response rates are radiographical. And so it was appreciated there was like a difference. I mean, this is like a grab, like it's just like it's a variety of like patients, even though they're within like these cancer sites, and that they're also receiving immunotherapy, but there's a variety of, you know, different disease states there. The response rates look to be different between the two groups. That is like that's a statistical difference, but there was no difference in their survival. So something is happening, maybe not detrimental, maybe it's beneficial to patients, but it can affect the assessment that your oncologist makes about your treatment. If it looks, we don't know that your survival is affected, but we know that your response, like when we do like a CT and we take a look at and it doesn't look like the therapy is working, that might mean a change of therapy. And so there are implications. So that, once again, like that discussion needs to be had, and this needs to be studied in a much more rigorous way because of the implications and how we're moving to immune therapy across the board. So practically, one of the things that we know, like in patients like with cancer that are using like cannabis, is that some of the symptoms from using cannabis tend to come on early on. So the blue is like multiple sclerosis like studies. We know that if we are able to carefully monitor and adjust like the dosage of like the cannabis in a supervised environment, that we can mitigate some of the direct like harms. So there are potentially harms that can come from interactions with like therapies. There are potentially benefits or harms like in some cancer sites like GBM. We know that we can potentially modulate the side effects. We also know that we should start low and go slow. This is like a mantra, like in medical cannabis. It's usually recommended for patients to start with like a balanced THC or CBD ratio of 5 to 5.6, but generally within a balanced ratio, partly for many different like reasons. But we know that the dosing needs to be individualized. We know that the average like individual that uses like medical cannabis, from like many studies, tends to use between 1 and 3 grams like a day. That a typical joint will have either 0.5 gram or 1 gram. That when you inhale, when you take a puff, so this has all been studied, usually consuming 25 to 50 milligrams of plant material, and that oral ingestion for the same, almost like the same effect, you need like 2.5 times more, just because of like how things are maybe not as available like through the gut when it gets absorbed as it is like through the lung, and then you got the liver. So to start on like cannabis, you need to have like an appreciation of maybe how much you need, how much you're taking via like which route, what your symptoms are, and documenting religiously like everything, so that you can adjust the dose in a way to meet like your symptoms. And this is all because there isn't like a rule book. It's very like individualized. Long-term issues that need to be like considered in all patients and in those with cancer is the idea of like tolerance. So this happens with opioids, where you need like more to get like the same effect, and then dependence, when you with like long use, you start to get like withdrawal like symptoms if you don't take it, and then you just need to take cannabis to basically feel like normal and not get a benefit from it. And so where are we like these days? So there's like I was saying, there's limited clinical like trial like evidence. And so one of the once again, like going back to like Israel, because of like the centralized like system, they followed like a group of like patients, a large like number of like patients. This is an observational study. They're just like observing like everybody. We're on various like journeys like through their cancer experience. Some of them are more towards like end of life. But what they found for those patients that for the majority of like patients, for the over 60% of patients that were able to stick with like the regimen over 6 months, that they did sustain a benefit in terms of like their pain, self-rated pain, and then also a sustained benefit in terms of like their quality of life. But not every, and that is compared to before treatment. Once again, this is like observed, right? So if we could design an ideal like therapy or an ideal like trial, ideally we'd want to be able to identify like the content and the dosage and sort that all out very accurately. We want to really figure out who might benefit and then figure out who might be harmed. So with that in mind, Dr. Pippa Hawley from the BC Cancer Agency, and this study can be accessed through either using that search term, that's like a hyperlink, but that search term, or the clinical trial identifier, the Cannabis for Cancer-Related Symptoms study. So this study just opened. So this has been in the works for like a few years, many like challenges, a definite like a shout out to all those who have been involved, and Dr. Hawley and her team in BC for all the work that needs to be done, and the funds. So this was like a philanthropic fund that essentially over $1 million to get this like study launched across Canada. We're hoping to launch this at the Tom Baker. So what is, thinking of the CAFCARS like study, what is an ideal medical cannabis like product? Well, it needs to be legal, it needs to be available. So we don't want a product that's available in the States, it's not available here. We want it to be affordable. That's been some of the concerns with some of the pharmaceutical products that I mentioned very early on in the talk. Needs to act like really quickly. Typically something that's inhaled will work within 5 or 10 minutes. Something like under the tongue or transmucosal, usually 10 to 15, which beats the 1 hour to 2 hours that you need to take if you had to ingest it. You want it to be free of pesticides and molds and chemicals. It needs to follow basically good manufacturing practice. We don't want to inhale it. It shouldn't, it's like an idea, it's like a wish list. It shouldn't smell. It should be able to have like a flexible content of like the cannabinoids and not be, and not like some of the pharmaceuticals that were developed like early on. It should contain, this is like a big thing with like quality assurance, right? Are you buying, are you actually getting what you think like you're getting? So if you're following good manufacturing like practice, essentially following practice for pharmaceutical grade like products, what's in the product is like what's on the label. And ideally from a study perspective, you want a placebo. So patients are using cannabis like we know without or with limited guidance. Side effects can be important, like especially with THC. A lot of the problems with like early studies that were done, like the randomized studies that I didn't highlight, is that they just started patients on a fixed dose. As soon as the patient stopped, that was basically deemed like a failure. So the dose was not ideally adjusted and not really considering like everything else that the patient was on. So this is like quite an important limitation. So I think this study will be very informative, if not definitive, in terms of like how it's like designed to answer this question in a way with the products that we have available to like us in Canada. Does medical cannabis like work for patients with like cancer? So the hypothesis here is that we can see an improvement in symptoms with the use of maybe one or different like extracts, and that the side effects should be mild, and that patients or subjects on the study will want to continue on with this product because it's going to be helpful to them. So these, so we want to, as the 3 objectives like in this like study, we want to identify whether there's an active basically ratio, a cannabis extract that's better than placebo, right? It has to be better than placebo. we want, or what is better than another for symptom control in totality. And then for the secondary objective, for the individual symptoms, are there extracts that work better than others for the different different symptoms that patients tend to have? And then we want to investigate the safety of this. So the way this study is essentially driven is unique. So this is like an N of 1 study. So all this means is that you are your own control. So that what that means is you get the 4 products and you're kind of rotating through with them. And at some point you run through the placebo, but you don't know it's a placebo because the flavor is like masked. And so that is, this hopefully will serve to make up for the shortfalls of like other studies that have been done in the past. And patients are self-adjusting like their dose. So this is a significant improvement. So the fine details, you're on the study for 16, I'm hopefully not selling you on the study, but patients are on the study for 16 days. They essentially 2 days in, they are not on any cannabis at all. Then the 2 following days, they're on the first like product. They're adjusting the dose. There's some recommendations as to like maximum quantity. Then the day 6 and 7, that's they're washing out. They're switching to the next thing, but there's nothing in their system. Then day 9 and 10, they take the next product, and they kind of do that over and over again for 16 days. And then that information is all like collected as part of like the study. The product is like sent directly, so the patients would be identified, that'd be eligible at the cancer center, and the product would be sent directly to their home, and they'd have a telephone follow-up with the cancer center and visits as required. They'd be using the Edmonton Symptom Assessment Scale. So there's a couple of scales scoring that we'd use to assess the response. And for the sake of time, just jumping to the slides, are you eligible? So as long, the focus really would be, as long as patients are having a cancer-related symptom, such as like nausea, pain, anxiety, or sleep disturbance that is scored beyond a certain like number, and that everything else is essentially like stable, like in their care and their cancer like journey, that they'd be eligible like for the study. And so certainly anybody with like a psychiatric illness, an issue with like substance disorder, an issue with like with the potential for pregnancy, or on medications that might interfere with like cannabis, those patients would be excluded from like the study. So we're currently awaiting ethics approval and completion of the clinical trial process. So we're hoping that this is able to open. I'm the local investigator here on this like study later this summer. It's on the agenda for the clinical trials group here. And information on this like study, if you put in your search engine this term, once again, this is like hyperlink, you'll find out some more details of the team leading this work in BC. So we started with essentially a very strong regulatory environment many years ago, where information around cannabis was like hard to find and fallen out of favor for healthcare providers and for patients like alike. And now we have essentially a mixed picture across like the country of how patients might be able to access like cannabis for their medical needs or their recreational needs. So a little bit of a test at the end, or maybe just like information that I was like alluding to like before. If you were taking, if you're trying to calculate how much you need of an oil, you can note that 25 to 50 milligrams is inhaled in a puff, and then you can note the proportion of THC or CBD in your product. Multiply those like together, you get the milligrams. If you want to ingest it, you multiply it by 2.5, and then you get that total amount. You find an oil that that has like a certain concentration, and you multiply the concentration with that amount that you need. And that's a quick way to get the amount of cannabis like extract with the certain THC or CBD that you're looking for. So I'd like to thank the group for for the opportunity for me to present some information that I'm hopeful has been informative and will lead to further discussion and further advocacy in this space. And thank you to Wellspring